I am delighted to be here today. I'm joined along with my colleagues, Dr. Allison Stubbe and Dr. Ann Kellums, to present First Do No Harm, Evidence for Exclusive Breastfeeding in the First Week. And to tell you the truth, this entire topic, this webinar, in fact, has had a very long gestation, beginning with the publication of an evidence-based review called Evidence-Based Updates on the First Week of Exclusive Breastfeeding Among Infants Greater than 35 Weeks. And that evidence-based review was the product of actually 10 authors that together went through extensive literature to provide for the audience of this review the updates on how best to support exclusivity of breastfeeding during the first week after birth, and was published in Pediatrics and will be available for you on the CHAMPS website. And so this webinar was intended to present an overview of that work product of all of us, but clearly with the pandemic of COVID-19, we would be remiss if we didn't really frame this evidence-based review in the context of the current pandemic. So with regard to disclosures, the only ones that I'll read out loud is that the presentation today will present the views of our own personal opinions and not that of any specific organization. So what we hope to do by the end of today is state how to support exclusive breastfeeding, and more importantly now, especially during the COVID outbreak, to support exclusive breastfeeding even after mother-baby separation, understanding that there are some facilities that are separating mothers and babies because of COVID positivity, and also how to counsel patients using a shared decision-making approach and presenting one strategy called the LOVE strategy. You heard one last week presented by Diane Spatz, and there's a lot of different algorithms for how to remember how to do open-ended, patient-centered, shared decision-making types of counseling. So what are the main issues? You know, really there's so many, we couldn't possibly cover all of the issues related to COVID and exclusive breastfeeding in one webinar, which is why there are multiple webinars on this topic, and I think that there are just more questions that arise really the more we think about it. But we're really going to focus on this issue of providing mothers expressed breast milk exclusively, or really allowing and supporting mothers to directly breastfeed, and how that really is different than anything other than an exclusively breast milk diet. How rooming in and as opposed to mother-infant separation really makes a difference in terms of getting started with breastfeeding, and how important cue-based feeding really is, and including other maternity care practices such as skin to skin and bathing the newborn and cleansing the breast or not. So there's all these new practices that have been promoted or intended to try to reduce the spread of COVID-19 and SARS-CoV-2. However, you know, we're still looking for evidence to support all the different types of guidelines that are out there. And you know, with that, there's additional questions that arise when there are extraordinary cases with maternal illness, you know, when the illness is really severe, and also in the neonatal population. So I wanted to provide a little bit of background on the virus, because I do think understanding the virus really does help us in understanding some of the recommendations, but also some of the rationale for why we should support exclusive breastfeeding. So SARS-CoV-2, the name of the virus, COVID-19 is really what we call the disease, but SARS-CoV-2 is really one of the common coronaviruses that have been around forever, leading to the common cold. There were a few really bad mutations that happened with the coronavirus that led to the SARS epidemic, or severe acute respiratory syndrome, that happened in about 2002 to 2004, and also the Middle Eastern respiratory syndrome, or MERS, That happened about 10 years later in 2012. And then this novel infection caused by SARS-CoV-2 that arose probably sometime in early winter back in 2019. So we call that disease COVID-19. And because of the fact that these mutations have happened in the past and the mutations really aren't dramatic, it's not hard to consider the fact that this happened in nature, probably within bats, as the primary source of these coronaviruses and mutations of coronaviruses that this novel COVID-2 would arise. So please indulge me for a minute and let's talk a little bit about the cellular and molecular mechanisms of SARS to really get a better understanding of this infection. So what you see before you is the genomic material of this virus. This is an RNA virus, and it's actually a positive sense single-stranded RNA virus. And what that means is that it actually mimics what we call messenger RNA, which serves as the template for how we make proteins. And because it's positive sense, it can get into the cell and immediately overtake, kind of hijack the mechanisms within the cell to begin to manufacture protein right away. It doesn't have to enter the nucleus or undergo any other kind of replication before doing its job to make all the proteins that are necessary to provide the house or the capsid or the crown, which is why they're called coronaviruses, the crown around the virus that protects the virus. Most specifically, part of that crown is coded for that red S area, that genomic S material, that leads to this spike protein. And it's that protein that actually binds the antigen of human cells and allows for the virus to enter. And that's really important because without that binding, you can have lots of virus, but if it can't bind, it can't get in and actually do its harm and actually replicate itself. In addition to hijacking the cell's own mechanism in making protein, it actually has a few genes that makes its own replication mechanism. So it could use the cell's mechanisms, but actually is able to do that right in the cytoplasm. So really a rapid amount of viral replication. So why is this such a bad actor? Because it's really a lot more deadly than is the influenza disease, which is, as we know, in and of itself really deadly. Every year we have an epidemic of flu, and we do see on the order of 5,000 to 10,000 deaths from that. And now, we have an order, 10, hopefully not more than that, fold greater deaths, mortality from this virus. The other thing is it's novel. So we haven't seen this virus. None of us humans have been exposed. So if you are exposed, you will get it. And probably the most troubling part of this virus is that probably the most contagious period of time is the day before you actually get sick. So you're out thinking that you're fine, and you're actually spreading the infection quite readily. So don't think that by avoiding sick people, that's the only way you're going to protect yourself in terms of being infected with this viral illness. So just a little bit more about this and why, particularly today when we're talking about neonatal infections, I think it's important to understand why children are less likely to get ill. As I mentioned, it's the spike protein that attaches what's illustrated here on this slide as the ACE2 receptor. It's the angiotensin converting enzyme, something important in blood pressure control. That receptor actually is where that crown spike protein binds and allows entrance into the host cells, most predominantly in the lungs and the heart, but there are ACE2 receptors really all over the body. So what's important is that actually the coding area for that receptor in children is not activated. So children actually are not producing the ACE2 receptor to the extent that adults, young adults, and not even as much as older adults are actually making. And so we think it's because of the lack of the volume of receptor status in children that children are actually not getting as ill. Although now, of course, you've all heard about some late sequelae once the virus has already left the body. of some hyperinflammatory immune responses similar to Kawasaki's disease. So this is a slide with data from a publication from WMMR. It's already like a month and a half old, but the point is here that children are less likely to get infected. And so in terms of total number of cases that are reported here, there are about 745 cases that are on this slide. But among those that were hospitalized and among those that actually needed to be in the ICU for respiratory support or other support, a greater proportion of infants less than 1 had to be hospitalized than in the older children. At least that was at the time as of April 2nd when this MMWR came out. But I think that if we probably relook at this and include now in all of the Kawasaki's diseases, which interestingly are happening in older children, this slide, and in terms of proportions, would probably look a little bit different. So what about Mississippi? This slide is a little bit old, but I will tell you that you haven't yet reached the point of the decline in cases. You're somewhat plateauing, but it's hard to tell if you're not even in the situation where cases are continuing to go up in Mississippi. And there's definitely areas of more prevalence. So the area surrounding Jackson, a little bit closer to where New Orleans is, and then some areas on the coast. And you see before you that at this point, which was only Friday, there were 9,090 cases, and as of today, there's actually 9,908 cases in Mississippi. So definitely your cases are going up. And as far as children go, you can see here, as of Friday, there were 379 cases. Again, as of today, there were 436 cases among pediatric patients less than 18. What's interesting and what you don't see here, when you break it down within the children, what you actually have in Mississippi is that 33 out of the 436 pediatric cases are among infants less than 1. And that's 7.6%, which actually is about half what it is nationally. So nationally, there's about 1% of the total national cases of COVID are in the pediatric population, less than 18. But in terms of how many are under 1 year of age, that's 15% nationally. And I would like to think, although I don't have data to necessarily support this, but I would like to think that all the good work that's happening in Mississippi in terms of getting infants off to a good start with all the good maternity care practice changes that have happened and the new baby-friendly hospitals, that there's more breastfeeding happening in Mississippi. And maybe the infants are actually somewhat protected. And so that's what this slide shows is just 29 as of Friday, but as I said, there's 33 cases as of today. So just in transition, these are the Make Way for Ducklings sculptures in Boston done by Nancy Shore. This was actually a tribute. There are multiple celebrations that occur with these amazing sculptures. And this is to pay homage to PPE, with the wearing of masks, hopefully as a good way to encourage folks to actually wear masks in public. So regarding exclusive breastfeeding, we know that exclusive breastfeeding on the macro scale is important. We know that it's dose dependent in terms of how intense breastfeeding is and how long exclusive breastfeeding lasts actually matters for health outcomes. But now we know even more about certain health outcomes that rely on exclusive breastfeeding. So without exclusive breastfeeding, you don't see these particular health outcomes being prevented, like low respiratory tract infections and serious persistent diarrhea. Also, some benefits are associated with direct breastfeeding as opposed to providing express mother's milk. And those include obesity prevention and the potential for reducing allergy. And that's important when we think about, what's the risk-benefit ratio of separation versus direct breastfeeding. So why is exclusive breastfeeding so important during a viral pandemic? Well, we've known over years that exclusive breastfeeding is protective for infants, children, and their mothers as well in terms of health outcomes. So throughout pandemics, over the years, our survival has resided on what we know best, which is exclusive breastfeeding. But there's new evidence that actually just came out in the last few weeks with investigators from University of Pennsylvania here in the US, as well as in Botswana, looking at something called the human virome. We talk a lot about the human microbiome, the bacteria that colonize in a good way the human gut from exclusive breastfeeding. But now we have even more evidence that human milk modulates the human virome. And in this slide, you can see a little baby at birth, which is usually devoid of any viral products. And the first wave of introducing viruses into the human is actually via the microbiota. They come with their own viruses that are not pathogenic, that are not harmful, and are hosted by the bacteria, probably in a commensal way, just like the humans host the bacteria in a commensal and positive manner. But the second wave is more problematic. And in the second wave, many viruses enter into the human host, some of which in fact are pathogenic, and human milk modulates the changes that exist during this second phase, such that in babies that are breastfed, they have less involvement of the pathogenic virome. So they have a more protective and less extensive viral infection in their gut and more, again, maintenance of the commensal bacteria. So this just provides some of one little slice of biological mechanism behind the importance of exclusive breastfeeding, why particularly in this pandemic, exclusive breastfeeding is so important. And how do we do that? Well, today we're going to talk about setting the stage for exclusive breastfeeding through prenatal education and support, depending on mom's COVID status, the maternity care practices, the things we know that help to get breastfeeding off to a good start, and then what happens after mom and baby leave the hospital. And in particular, regarding the manufacturing of milk, during times of stress, we know that stress inhibits the milk ejection reflex. And so it's important that in a pandemic that we support mothers, we give her the confidence that's necessary to either directly breastfeed or to help express milk. And then also really think about, in a very critical way, anything that would interfere with the usual support of exclusive breastfeeding, with the usual support of establishing the healthy microbiome of the infant's gut. And then finally, many mothers and babies are at risk for having problems with exclusive breastfeeding, which is why we got started to write the state-of-the-art review in the first place. And that hasn't gone away. So we still have the same issues of hypoglycemia and hyperbilirubinemia and the potential for excessive weight loss. And we can't forget that. And so it's really important that we go back to basics in terms of supporting breastfeeding and looking at mothers and babies, looking at the latch and looking at how the baby's weight is going. And this is just a cartoon to show that the healthcare provider is illustrated here as a pediatrician flying in somewhat like an angel, yet, we know that mothers and babies have a lot of the good techniques and good support from all of you on this call to continue exclusive breastfeeding. And with that, I'm going to hand it off to my colleague, Dr. Allison Stubbe.
Hey, everybody. It's delightful to be here today virtually and to talk about some of the considerations when we think about separating moms and babies. And I think that I got to thinking about this last month in writing a piece for Breastfeeding Medicine in my president's column, because there was a lot of kind of knee-jerk reaction, like if mom is infected, the best thing we can possibly do is take the baby away from the mom because then the baby won't get infected. And I think it certainly stands to reason that if mom has an infection and the baby is nowhere near the mom, the baby is less likely to get that infection. But winning in this particular scenario is not having mom and baby be discharged with the baby not having been breathed on by the mom. There's actually a lot more to a good outcome for moms and babies. And so I think there are a number of things we need to think about when we talk about separation. One is that separation may not prevent infection. In a series out of China, there were several babies who were born by C-section and whisked away to a separate place who nevertheless tested positive for COVID. So it's not clear that that is a bulletproof strategy. And more importantly, when that mom and baby go home, not many of us have the social support, material support, and space to continue isolating that mother-baby pair for 2 to 3 weeks until mom is no longer infectious. And there's a very good chance that if mom has COVID, other people in the household have it as well. So we can separate them for 48 hours, but we can't guarantee that separation. There are also some really important physiologic reasons that this is a bad idea, and we'll talk about those in more detail in the next couple of slides. Interruption of skin-to-skin disrupts newborn physiology. It also stresses out moms, and if a mom is ill, stressing her more is probably not a great idea. We also know that separation interferes with provision of milk, as Laurie has already alluded to. And if we disrupt breastfeeding, we may actually increase that child's risk of developing a severe pneumonia down the line. And then finally, and really pertinent to all of us who are using our surgical masks for 2 or 3 or 4 days before passing on to another one, separating mom and baby means twice the amount of PPE to care for the dyad. So next slide. Can somebody take me to the next slide? Not sure who's driving. So I think the first thing that's really important, and this is fundamental to the work that we do with 10 Steps Care, is that skin-to-skin is really important. When skin-to-skin is disrupted in a Cochrane meta-analysis of randomized trials, mamas and babies weaned 64 days earlier than when they had the opportunity to be skin-to-skin. And these are data from randomized control trials. So this is not a situation where the crunchy mama with the birth plan who planned to breastfeed until 6th grade ended up being the one who breastfed longer, and the mama who was like, ooh, gross, wash the baby was the one who weaned earlier. These are randomized control trials. So that presence of skin-to-skin gives you 2 full months more breastfeeding than separation. We also know that babies who are separated have lower glucose levels. 10.49 milligrams per deciliter lower. And that can be the difference between a hypoglycemia workup and a stable baby. So when we take that baby away from that mama, we're stressing that baby. We also know that babies who are separated have reduced cardiopulmonary stability. So again, if we're worried about a late preterm baby who's being delivered because mom is really sick, and we then take that baby away, we may be actually making that baby more stressed. Next slide. We also know that separation stresses moms. And this is a really wonderful study that looked at mothers whose babies were in the NICU. And they measured various markers of stress, both heart rate and cortisol in the top left and bottom right corners, and then also maternal mood scale and a visual analog stress scale. And these measurements here are the first and fourth time the mom and baby did skin-to-skin. And they have the before, during, and after. And what you see is that cortisol levels drop, stress levels drop, heart rate in mom drops, and mood improves when that mom is holding that baby skin-to-skin. And so if you think about a mother who's stressed and you separate her from her baby, we're increasing mom's stress, increasing her cortisol response, increasing her heart rate, and therefore making her less safe. I came across this early in my maternal fetal medicine fellowship when I was caring for a mother who had had runs of non-sustained ventricular tachycardia. And so she was actually admitted and on a cardiac monitor for much of her pregnancy. And when she was postpartum, when the baby was skin-to-skin, her EKG looked great. When we took that baby away, she would start to throw arrhythmias. And so there was this very clear relationship between separating that mother from that baby and really endangering that mother's health. And so we need to be thoughtful. If a mom has a diagnosis of COVID, that's incredibly stressful in and of itself. And if we then take her baby away, we may actually be compromising her recovery. Now, next slide. So we also need to think about the importance of human milk as medical therapy for babies and reducing their risk. And this was a study that looked at the time between vaccination with pertussis and then development of IgA specific to pertussis in human milk. And what they were able to show is that at 7 days, you already start to see more IgA in the milk of the moms who've been immunized. And by 14 days, there are even higher levels. And so if that mom has had COVID for a period of time before delivery, her milk may actually contain antibodies that directly protect that baby. So while certainly donor human milk is also a good thing if mom and baby are not able to be together, mama's milk when mom has COVID actually may be precisely what that infant needs to protect that baby from infection. And so it's critically important that we get that mom's milk into that baby so that that baby can benefit. Next slide. And then I think we need to think long-term. So this is a meta-analysis that looked at studies of exclusive breastfeeding versus artificial feeding and hospitalization for lower respiratory tract disease. And what they found is that infants who were formula fed were about 3.5 times as likely to end up in the hospital with severe pneumonia than infants who are exclusively breastfed for at least 4 months. So if we mess up exclusive breastfeeding in the early period after delivery, in the name of protecting the infant from COVID, we actually make it more likely that that baby will be hospitalized for a lower respiratory tract infection. And that could be COVID the baby gets later, or that could be RSV or the flu or other conditions that we know affect many neonates in the first year of life. So we're really doing a disservice if we don't support breastfeeding as best we can. Next slide. And then last, there's this issue of twice the PPE. So if mom and baby are together, one provider in one N95 mask, in one full-on PPE can go in and take care of that mother-baby as a dyad. If mom is in one room and baby is in another room, that's twice the hospital rooms, twice the gowns, twice the masks, twice the face shields in order to provide care for that dyad. And so when we think about health system resource allocation, we really need to be thoughtful. If we knew for sure that this was safer, like this is true if mom gets varicella within, I think it's 2 days before delivery, there is a really good reason to separate that mother and baby. This is not that situation. And we are incurring risk to our healthcare providers by demanding twice the resources to take care of that dyad. Next slide. So in light of this, ABM issued guidelines in March regarding how to think about breastfeeding in the setting of COVID. And what we recommend is that if the mother is well and it has mild or is a PUI with mild symptoms, it's very reasonable for mom to breastfeed. And we, consistent with CDC and WHO guidelines, recommend using a mask and washing hands carefully to minimize risk. It's important to make sure that mom has that mask and has the ability to keep her hands clean. Next slide. And in terms of housing that mother and baby, there's a suggestion that if the bassinet can be kept 6 feet away, that may reduce the risk of transmission. Sometimes that's logistically possible, sometimes it is not. Ideally, there could be another well adult who cares for the infant in the room if that's possible, but that is not a requirement to allow them to be together. Another option is temporary separation, and that they thought was primarily in the setting when mom was very ill and needed medical care for herself in the hospital. So we've had a couple of mothers who came from the NICU, delivered, and went back to the NICU. And clearly in the medical intensive care unit on hypoflow cannula or intubated, it's not practical for the baby and the mom to room together. And in that case, we facilitate expression of breast milk and provision to the baby. Next slide. Critically important if there's separation to sustain breastfeeding and help mom with milk expression to maintain her supply. Ideally, she should have a dedicated breast pump, so we're not taking the breast pump out of the room with mom with COVID and into another room. Hand hygiene is terribly important. And then washing all the parts of the pump after breast milk expression is important. And then that expressed milk should be fed to the newborn by a healthy caregiver. Next slide. So I also wanted just to pause for a moment and acknowledge that whether mama has COVID or not, this is a really stressful time to be a new parent. And back in September, a team from UNC that I'm a part of launched newmomhealth.com. And this was designed as the first national postpartum information source designed by moms for moms. And our goal was to acknowledge that there's a lot of attention paid to taking care of the baby after birth, but there's less attention paid to the needs of mamas. And we wanted to be able to meet those needs and answer mom's questions. Next slide. We have a couple of core values. One is that health information should be honest, accurate, clear, high quality, and based on the most current science. We also really believe that women are resilient, strong, and capable of making quality decisions for themselves and their families, and that communities and health systems should care for the mother rather than demanding that she access care. Next slide. We have a special section of the website specifically about COVID-19 for new moms. It talks about the importance hand hygiene and issues that we've discussed, but also about strategies for coping and about the difference between social distancing and emotional distancing, and strategies for moms to get the support that they need. Next slide. The website also contains a variety of information about all the different parts of mamas that face challenges in the postpartum period. And this was co-developed with input from groups of mothers who helped us realize, I think at one point this section labeled bottom pelvic was called perineum, and they all said, what is that? And we were like, oh, right, that's not a real word for normal people. And so bottom pelvic was chosen. We also talked about what words to use for depression and anxiety, and our stakeholder mamas said they didn't want depression and anxiety, they wanted emotions and hormones, and so that's in the lower left field. All of this content is written very much with the idea that mamas are able to make good decisions for themselves, and it offers options rather than making sweeping statements that you must do A or B. Next slide. Another really important part of this website is this concept of building my village, and thinking about what support and care looks like for each specific mama. And so there's a section on my family and friends about dealing with not so helpful helpers. So if you have a beloved friend or family member who's telling you you must do A, B, C, D, and you want to do E, F, G, H, how do you handle that, and how do you deal with that? The section on my partner includes, what if I don't trust my partner to take care of my baby? How do I get over that? So it's a really comprehensive resource. So I encourage y'all to check it out, and please send feedback. If there are things that aren't there that should be there, please let us know. Or if you have suggestions for additional material, we want to know that. So next slide. And yes, the URL is newmomhealth.com. I see that popping up in the chat. So I'm going to turn it back over.
Okay, I'm going to touch a little bit on breast hygiene and then talk about discharging the newborns and caring for them once they're out of the hospital or in the immediate postpartum period. So as far as breast hygiene goes, I would say the consensus is that it probably does make sense for mom to keep her breasts covered and not be coughing directly on them. There were some that were recommending breast cleansing prior to every feeding, and that probably is not practical. And we also know that soaps and detergents and products, wipes, things like that, all can cause damage to the skin. So what we're doing at our hospital is having mom change into a clean gown when baby comes in, keeping the breasts covered, and then when she feeds the baby, exposing them, going back, showering once a day. So I think sort of being reasonable and avoiding things that would do harm here are good. Next slide. When you're thinking about discharging the dyad, there's really two ways you can go. One would be that mom and baby are going home together. We would still recommend, similar to in the hospital, that she's hand washing every time she touches baby or anything to do with baby, that she wears a mask when she's within 6 feet or holding or breastfeeding the baby, that we figure out what kind of support system she's going to have at home. They would need an in-person follow-up in 24 to 48 hours, potential telelactation or help in one-on-one, face-to-face. And then there's options for home care in some hospitals and communities where they can have a weight and billy check and then perhaps a telehealth visit with the pediatrician or family physician, nurse practitioner who's caring for the baby. There's also the option of discharging them separately to a well caregiver. I think one of the issues I have with this as well is in quotation marks, because you know, we don't know, like Lori was saying earlier, asymptomatic people can be exposing other people to the virus if they don't know they have it yet, and they may have already cohabitated with mom and may have already been exposed. So it's hard to know who that right person would be. They recommend that mom can reunite with baby if there's been no fever for 72 hours without the help of Tylenol or Motrin, and more than 7 days since the symptoms started. We'd want to be encouraging mom to be expressing milk, establishing and maintaining that milk supply, and getting it to the baby. And we would need to be thinking about who we're giving discharge instructions to, because probably mom of the baby, as well as whoever the caregiver will be, will need that. Next slide. So for the baby going home, we need to find a place or a way for this baby to be seen face to face, usually within 24 to 48 hours after discharge. So that can be challenging, finding pediatric practices. I know people have been.
I think her screen her technology just froze. So yeah, it's so important that we can see the baby, to see breastfeeding, to do an assessment of breastfeeding, and to do a weight that is reliable. And so I know a lot of pediatricians have converted their offices to be primarily telemedicine only, but there's a few exceptions, and we really do recommend that the baby actually be physically seen, to do a first assessment after leaving the hospital, to do a breastfeeding assessment, and to do a weight, because many scales are not reliable, and it's important to get a reliable weight so that we can determine if there's any problem with excessive weight loss. Certainly subsequent visits can be done via telelactation.
I'm back.
Oh, good. Okay. Thanks, Anne.
Great. Laurie just did that slide for you, so you can pick it up from here. Thank you, Anne.
Yes, thank you. So I think you were talking about telemedicine. This is from a colleague, Kathy Leeper, who has been doing a lot of telemedicine. And obviously for a prenatal consultation or going back to work, using a pump, maybe troubleshooting some rashes or nipple pain, it's appropriate. But those newborns, we really want to try to see in person whenever possible. Next slide. We do have this from the Centers for Disease Control released recently, and they were distinguishing between essential and non-essential visits for pediatric patients. They do consider newborn visits, i.e. infants younger than 1 month of age, to be essential. So for those of you whose hospital systems have restricted that. Another tool, if you haven't heard of this or used it, I highly recommend it. It's newbornweight.org is the website. These are based on over 100,000 babies, and it has been validated in multiple populations. This is looking at healthy breastfed babies who are not sick, who are not hospitalized, do not have severe jaundice, have not lost or have not been diagnosed with dehydration. And it looks at their birth weight and the percent they are down from their birth weight over the first 1 week and then 1 month. And so this is an example of a baby who plotted right about between the 50th and the 75th percentile. So that can be very helpful information. It might mean, hey, we're doing okay, but let's look at the latch and let's see if we're transferring milk, and let's find out from mom if she's noticing any breast changes. And then we might want to see this baby back in 1 to 2 days until we get into the I'm starting to go back up, I'm getting towards the green zone. Next slide. So this is one of the absolute most important reasons to see those newborns in person whenever possible. Is it's our job to be looking for signs of inadequate intake and dehydration. We know that a lot of mothers are worried about whether their babies are getting enough, and they're really relying on us to make sure that they are. So we want to make sure that the baby's having at least 1 good bowel movement per day, that the baby settles after the feedings, is not, frantic and just crying and crying and crying. And there is such a thing as cluster feeding, but each time the baby goes back to the breast, they should be happy for a while because they're getting some of those drops. Looking for the crystals in the diaper, feeling and observing their mucous membranes and their skin turgor. All of these things here are very important. And of course, we know that babies, even in the first 2 days who have showed no signs of jaundice, can still get into trouble in the first 3 to 5 days for a term baby and up to 7 to 10 days for a preterm baby. As they get older, you want to see those stools changing to yellow color by day 5. They shouldn't be still losing weight after day 4 or 5. Once lactogenesis stage 2 occurs and mom's making ounces, they should be going up steadily. We look for an average of 20 to 30 grams a day, and then back to their birth weight by 2 to 3 weeks of age. Next slide. If you're noticing that any of these things are there, it's not automatic formula supplementation, because we need to figure out how they got there to begin with. Is this a maternal production or supply problem? Is it because the latch isn't effective, or the baby is having trouble attaching to begin with? Is mom having a letdown reflex? Are there drops there to get that we need to maybe help her express to get into the baby? Or is there something going on with the baby? Is this not just a breastfeeding problem, but maybe their sugar's low, or they have high jaundice level, or they're infected? And so it's a multifactorial problem that needs a multifactorial answer. Next slide. This is the Latch score, which is embedded in our electronic medical record, but we use it to talk about how can I tell if breastfeeding is going well in the first, within about 5 seconds. And basically, it's easy to remember because the letters stand for what you're looking at. So lips splayed, you want that baby's mouth open as wide as a yawn, and almost 90 degrees from nose to angle of jaw to the chin. You want to be able to hear audible swallows. You want mom's nipple to be poking out and not smushed or rubbed. I have a picture on the next slide to show you. Asking about C for comfort. So how does that feel to you every time the baby gets back on?
Yeah, I'm going to move on. Yep.
Next
Yeah, now
slide.
you're back. There we go. Yep.
Okay, so this is just an example here of what we'd like the nipple to look like after a feeding, whereas the ski slopey appearance means the tongue has been rubbing here, and then this smushed feeling where the nipple's getting like a pancake, and sometimes you'll even see a compression line or a stripe there. Next slide, please. So you don't want to see the infant's cheeks indenting or clicking sounds or their lips curled inward. You don't want the infant to be just continuing to be frantic and moving around. You really would like to see them settle. Sometimes their eyes pop open and they start to get really interested in what they're doing. And mom shouldn't be having pain or discomfort during the feeding. Later signs can be you're seeing damage or trauma to mother's nipples, even if she says it's going okay or she feels okay. You don't want to see inappropriate weight gain or appearance of the growth curve for the baby. And it really is about the angle. So baby's chin will be very far back from the nipple, almost at the border of the areola, and the nipple will be very close to the nose. Next slide. The other thing we look at when the baby's feeding is the suckling pattern. So the top line is a baby who gets on and does the initial quick little suckles, and then go-gung, go-gung. So that's a baby who has triggered a letdown and is getting a swallow and a swallow. The second line here is suck, 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 one swallow, suck, 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 one swallow. That'd be a very typical newborn in the first 1 or 2 days, maybe 3 days before lactogenesis stage 2, where the ounces of milk occurs. The third line down is a baby that is not feeding or transferring milk. So their mouth is moving and they're pausing, and then it's moving a little bit. This baby is either sleeping or ineffective or uncoordinated. By day 4 to 5, you want to have several periods during a feeding of ga-gung, 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 one suck and one swallow paired up and just going on and on and on. And then there may be a pause, and then there may be another letdown, and this continues. So that's a great thing to be watching for. Next slide. I want to call attention in our state-of-the-art review that was recently published that Lori mentioned. We have a kind of an algorithm to help you support decision making. And the bottom line here is, if the infant has signs of insufficient intake, first figure out why and what's going on. Maybe it's a latch and milk transfer issue, and mom has milk there, But if we don't start getting it out, that will affect her supply. And obviously we want that to all be going into the baby. So it's really working to assess not only what the infant looks like, but what the dyad, how the dyad is working, help them fix and manage that, and help mother, if we're going to supplement with something other than her milk, help her establish and maintain her milk supply. Next slide. And I think turned over to Lori.
Thanks so much, Anne. So just to close, one of the strategies for figuring out how to support exclusive breastfeeding, especially during the COVID epidemic, is to embrace this concept of shared decision-making. This is truly the manner in which we can provide the best patient family-centered approach to care. And as we say very often within the USBC, we engage families at the speed of trust. No one of us really understands the walk journey of the families that we care for, and we all come with our own implicit bias. And the way to get around that is to really have this engagement of shared and humble, honest conversation with caregivers, with the hospital staff, or with the providers and the families that they care for. And one of the things we should be aware of in this study, interestingly, among staff members, among more than 2,000 staff members among hospitals, we asked what were the main challenges in supporting exclusive breastfeeding, and they said it was the lack of social supports, the lack of breastfeeding role models, and supplementations given in the hospital. But when we asked the mothers, they said that they worried that the baby wasn't getting enough milk, and that they worried about going back to work or pumping, and they also worried about the baby not being good at latching and maybe seemed to prefer the bottle. So clearly there was a disconnect, and we need to become better listeners. So how do we do that? How do we be better listeners? Well, one way is to provide a safe space to give time. I talk very fast. I'm from the Northeast. You know, we sometimes just need to take pause and to allow mothers to just tell us what's going on, what they're afraid of, how they feel. And by probing and validating feelings, and I'll provide for you again the LOVE acronym in the next slide to really help frame this. And lastly, to acknowledge bias. You know, I think that if we can call it out and say, well, you know, this is what I've heard of, this is what I've experienced, then we're all on the same page, and we can, in a very humble way, acknowledge what we might be thinking that may be completely off base. So the LOVE approach is really all about listening to what moms are saying, asking open-ended questions, and then probing. And most importantly, and the thing we often forget or maybe haven't even really learned how to do, is to validate feelings. It's through this process of validating feelings that we can actually make a connection with each other as humans, and really know that the human experience is something that is emotional and that we can connect. And it's after that that any bits of information, and they should be on point, are really heard. And this falls very nicely into what we often say is the best kind of medicine, which is evidence-based medicine. But when we talk about evidence-based medicine, very often we only focus on the red circle, the evidence, the actual scientific literature that tells us what to do. But in fact, as Sackett described many years ago, evidence-based medicine is really a triad. It's the combination, equal proportion of the relevant scientific literature with our own bias. Not only do we have bias from our own personal experiences, we have bias because of our clinical experiences, and I call that Bayesian. It is sort of a mathematical statistic for how we are slanted in some ways based on what we see. We have one really bad case that stays with us forever. Every case that's similar to that, that we take care of afterwards, we're always a little biased about that memory. And that affects our clinical judgment. So really being honest and open about that. But then finally, and really again, in that equal proportion, we need to hear and understand and value the patient's own values and preferences for the care that they receive. So in conclusion, the evidence about COVID is emerging. We're learning new things every day. The pace is alarming to any of us that have had the privilege of thoughtful decision-making. And now we're really responding really daily to new pieces of information. But with that, I think that history has confirmed the rationale to support exclusive breastfeeding. So despite the fact that we're being bombarded by new information all the time, there is sufficient evidence since the beginning of man that really exclusive breastfeeding is the thing we should always come back to and feel confident in saying now more than ever we should support exclusive breastfeeding. Lastly, I want to share with you sort of one strategy. And just like in the operating room, we take a time out to make sure that we're operating on the right part of the body, where you have the right equipment, that the right people are there with the right patients there. You know, so this whole process of taking a time out before we do something has actually been shown in the evidence to be a good thing to do. And I would submit to you that in these times when the pace of learning and the pace of change and the pace of reacting to everything that's happening is really a good time to, in fact, take a time out. And the time out that you take is really to allow for this shared decision making. So before you think you're doing the right thing because you're just acting on the latest protocol, time out, talk to patients, listen to patients, and hear what they're saying. And with that, I will stop for any questions. Thank you.
Thank you all very much. It was great. There was so much covered in that presentation. So thanks to all three of our speakers. We have a lot of stuff going on in the chat. There was a lot of discussion of growth charts and using the new tool, the value of or the possibility of doing that in different countries, which I think we probably won't go into now, but we definitely are going to take, I'm noting here that so many people are interested in these tools, that certainly this is something that we can address on a future webinar. I just had a couple of general things that, you know, I thought I would comment on as some of these things came up. We do with Cheering, the group that I run in Greece that works with refugees, we do a lot of this sort of emergency first week and thereafter coverage for mums with babies who don't have any access to pediatric care. And it's just really interesting that now suddenly in this country we're dealing with the same issues, and actually we have got some tools about the first week which cover in pictures some of the things that you were talking about that Anne was addressing there. We actually have a presentation that some of our WIC officers in this country have used, so we'll be sure to get that out to you afterwards as well. So just to talk through some of the questions in the chat here that go to the various presenters. We did have quite a bit of chat about what's going on in the community or with some of the different offices or pediatric care centres that are actually doing different things, which is really interesting. I know that my hospital at Boston Medical Centre, we have basically got now a mobile unit of our paediatrics team that goes out to the community and does vaccinations. We also have set up a tent in the parking lot or somewhere near the hospital where all our paediatric patients are coming. So each hospital is definitely looking at some of this, and I think that's actually what the cartoon was about that our hospital put out. We do have a question that maybe one of our speakers would like to address. This was early on in the conversation. Someone asked, could you mention the mother-baby contact when the baby is in the NICU for many days or weeks after the mother is discharged and the mother's not, COVID status may not be known? Can anyone address that? What do you do about those long-term NICU babies?
So I think that we're negotiating this issue with our hospital right now about when is that mom's COVID status negative. So this is, if the mom already had COVID, there are several definitions, one of which was shared in the slides. I think Anne shared that afebrile 72 hours off of antipyretics without symptoms is considered to no longer be infectious. At our institution, they've said 21 days after the positive test, they're really sure they're not infectious. That's a long time, but that was felt to be easier than doing repeat testing, which is another strategy. You know, I think it's tricky because particularly if you're in a NICU situation where there's 6 babies in a pod in the NICU and you have a mom come in with COVID, that is complicated. And so it really is going to be fairly specific to the local setting, but I think there's very clear evidence that skin to skin for NICU babies is critically important to long-term neurodevelopmental outcomes. And so advocating for a policy that quickly gets that mom and baby back together again, as quickly as can be considered safe, is really important.
Okay,
So,
great, thanks.
Yes, some follow-up on that as well. Thank you so much, Allison, for answering. So the CDC has modified the 3+7 to 3+10. I think there's new data actually to establish the fact that the period of potentially carrying or harboring live virus and contagious virus is actually extended now to 10 days from onset of illness, as opposed to 7. So just, I wanted to clarify that, because that's happened even since the slides came out. But that's for the COVID positive mothers. I do also want to add to the fact that when mothers are in the NICU, she herself makes milk that is specifically protective against all the pathogens that are in the NICU. And so it's really important that the mother be there in a NICU environment so that her milk is perfectly suited, in fact, to meet the protective needs of that baby.
I had a question which also speaks to some of the questions in the chat here. Have we actually seen, or do we have any evidence of increases in complications in newborns being discharged? Not actually COVID, but all the things Anne was talking about. Do we know if, Anne, if those things have actually surfaced as problems, and we're seeing an increase in that population of children that are not fed well or are losing weight? Or I'm just curious if anyone knows.
I have not seen anything published, but on the pediatric hospital medicine listservs, particularly in hotspots for COVID-19 in the US, there have been reports of very, very low pediatric admissions overall, but the ones who are getting admitted are newborns with jaundice and dehydration. So I do think that across the board, people have seen that the earlier discharges have had some consequences. We'll probably have some data after this, I imagine, retrospectively, but that's the buzz on the listservs, that, you know, our unit is empty. We just have newborns who got discharged early and now need phototherapy or something like that.
We've got millions of questions. Let me see if I can get through some of them quickly. Laurie, you're going to stay on, so unfortunately you're going to have to wait a minute.
I'll wait.
Stay on for us. Okay.
And I have to go as well.
People paid homage to the fact that it's very difficult to work with patients when they're wearing masks. Somebody asks here, would you consider that donor milk for medically indicated supplementation instead of formula is effective in exclusivity rates? I'm not quite sure what that means. Using donor milk.
I actually posted a response to that in the box, and then I have to go. But there was a paper just out in Journal of Perinatology about exclusive breastfeeding among infants in the level 1 nursery supplemented with donor milk versus formula. It's not a randomized controlled trial, so how much of that was the mamas who really wanted to breastfeed wanted donor milk is hard to tell, but they did have higher breastfeeding rates and follow-up in the mamas who, when supplementation was indicated, used donor milk. So, and unfortunately, I have to go get on another call.
So we thank you, Alison and Anne, because I know that you're learning, and I really thank Laurie, who's volunteered to stay on. And I do appreciate that you guys were staying with us till 2, and it's now 2, and you're all busy doctors. So those of you, including those on the chat who have to leave, or on the thing who have to leave, thank you for being with us, and thank you very much for those talks, Anne and Alison. So we will stay on. We are on for another half an hour, and thank you, Laurie, for helping out here. So I'm going to go through the questions on the chat in order they were put in, so that people who put earlier chat questions had the have the priority here. So as labor and delivery, how do you recommend babies be transferred, with mom, skin to skin, or in a transport isolette?
I think a lot of it depends on, you know, the equipment that you have, particularly during surge. A lot of the hospitals don't even have transport isolettes anymore. So, so they can be transported if the transport team is trained and is aware of how to do it properly, you know, from a safety perspective, skin to skin with the mother. So that is definitely an option for how to transport that baby and mother together. And maintaining skin to skin up to the mother-infant unit.
And here's a question that you love, Laurie, to answer. On a positive COVID mother, is bathing the baby recommended immediately, or should it go skin to skin? And I think you might want to address the whole issue of bathing the baby, since it's one of your areas of interest.
Yeah, so I looked extensively to try to find evidence for bathing the baby immediately when a mother is positive for specific infectious diseases, in particular the ones in which we have already had guidance to bathe the baby immediately, such as HIV and hepatitis. And I could not find any primary sources, any research studies that actually provided the evidence for doing that, beyond just wiping the baby clear of wet and bloody secretions. And in those viruses, the mode of transmission is primarily via the blood secretions. And so that would seem sufficient to me. There's definitely good reason not to bathe the baby. And it has to do with not only the temperature control of the baby, so preventing hypothermia, but also protecting breastfeeding in the 2 studies that have been done. And the studies that really haven't been done suggest that there might be more to the baby's skin in its own microbiome and way of protecting that baby's skin from invasive pathogens than we know about. And I think that's just an area that's not studied. So what I would say is that, you know, given the way in which COVID is spread, you know, through droplets and respiratory secretions and through touching fomites, that other than just drying the baby of secretions, the rationale to actually bathe the baby isn't really there. There's really no evidence to do that. So I think there's good reason to push back on that and say, you know, how do we know that bathing the baby is really the better thing to do here?
Thank you. There's a couple of things in here that I'm going to ask my team, Mital, you're sort of the point person for this, to note down for future webinars. Several people have discussed how to be empathetic towards the patient during wearing PPE, which is something that must be of a topic not just for our maternity unit staff. So let's put that down as something for future. One thing I did see, which was very nice, was some healthcare providers have huge ID badges with a big picture of themselves smiling, so that, like, even though people can't really see their faces, they can actually see a photograph of what the person under the mask looks like, which I thought was a really nice one.
Yeah, and there's clear masks too. Some masks actually have a little plastic area where you can see the person's mouth, which I think is helpful.
Nancy Hurst said, and actually this helps me to talk to you guys in Mississippi a little more about this. Nancy Hurst here says that they have seen a 9-point increase in their exclusive breastfeeding rate in the healthy mother-infant population this time. And I know some other people in our surveys that we've done already with Mississippi have said that they think that because of the lack of visitors, people are breastfeeding more. We are tracking the rates in Mississippi at all our hospitals closely during this period, and we're about to send you guys another survey. So please do help us by like filling all of this out so that we can kind of document, at least in our own community, when we say our own, our CHAMPS community, we can see that. Ohio apparently is also seeing increased breastfeeding rates.
Well, can I talk just 1 minute about that? So, you know, the question earlier was about whether we're seeing increased hospitalizations due to separation. And I will say that in addition to the complications that can arise from sort of not well-managed exclusive breastfeeding, we also see premature weaning, you know, and the situation where mom who was not intending on not breastfeeding and formula feeding now is in a situation where she's formula feeding. And definitely in places like New Jersey, but elsewhere as well, there's formula hoarding and shortages. And so we have seen readmissions for hyponatremic seizures from families that have either been feeding water alone or watered down formula. And I suspect that even some of that increase in exclusive breastfeeding is the worry that there won't be formula, that formula availability, not that we don't have a supply sufficient in the country to support formula feeding, but just the access to available formula may be very different depending on the community that you're in.
Nancy says that this, unfortunately, at the same time, they saw a decrease in mother's own milk feeding in the NICU, which is an interesting. I do hope all of you out there, America and other countries, because I see we have people from many countries on here, are tracking your breastfeeding rates. And I would just say, don't make the assumption. A lot of people, not a lot, several people have been saying, oh, we've increased our breastfeeding rates because there's no visitors. And I would agree with Laura that there are many reasons that we can't make those leaps of logic. We can't say it's definitely because we don't have visitors. If you really want to find out, we can, you can ask your patients and find out from what they're saying. But we don't know for sure why some of these changes are happening. First of all, it's just interesting to see they are happening. I think we're a little bit caught up here. Does anyone have anything else they want to ask? If you do have it into the chat, or dare I say, people can open their microphones if we have another 15 to 20 minutes or so that we are willing to be on the phone here. So if people have other questions or would like to ask questions directly, please feel free to do that at this time. Just open your microphone if you want to speak.
I'd like to ask a question.
Go ahead.
Hi, my name is Gila Zarbiv. I'm a midwife from Israel. I was wondering what the pediatrician's thoughts were regarding the cardiac phenomenons that we're seeing in pediatric patients and the inflammatory response we're seeing in pediatric patients.
Yeah,
Great.
so
thank you so much. This webinar was.
Thanks for being on. We're kind of in a hot spot in New Jersey with the hyperinflammatory responses, Kawasaki's-like syndrome. And curiously, these are really conditions in older children as opposed to in the typical Kawasaki's age range under 2. And it's well after the individual clears. So the patients seem to have a positive IgG for COVID or SARS-CoV-2. However, a negative IgM, and they are SARS-CoV-2 PCR negative. So they no longer have virus, and it's usually several weeks later. So why is this happening, and how is it happening? It is a component of a hyperinflammatory response of the innate immune system. And I won't extend my privilege to indulge the group with CHAMPS, because I could just go on forever about the immuno benefits and immunopathology of risks of not exclusively breastfeeding, and really how the immune system is altered through exclusive breastfeeding. It's one of my favorite things to learn about and think about. But in addition to the SARS-CoV-2 virus binding the ACE2 receptors, there's also sort of a late phase innate immune response that happens with the virus that triggers some of the toll-like receptors and innate immune inflammatory responses. And as I've always talked about with exclusive breastfeeding, in the ontogeny of the immune system, there's a balance between tolerance and inflammation. And really, you don't want any more on one side of that balance to be activated than the other. You really want a little bit from both sides. And what we think might be happening here with SARS-CoV-2 is that there's actually a hyperinflammatory response. We're not sure why these certain individuals have that. I've been begging my colleagues in the children's hospitals to actually ask about breastfeeding. I think it would be a curious question to ask about their early exposures to an exclusively breastfed diet versus a partially breastfed diet versus formula-fed. I know because these kids are older that recall bias is part of the problem with doing that, but I've been curious about that.
Laurie, do you have
yeah.
any sense of the scope, like how many of the people this is affecting, and whether those kids might have had underlying factors to begin with?
Right, so they're previously, quote, healthy children, and then all of a sudden fall ill with, it's a little different than Kawasaki's because they develop a shock-like syndrome, so they become hypovolemic and very often have to be in the ICU for fluid support, and they're spacing, so they're really puffy. And some actually have clotting irregularities, so they might throw a thrombus to certain organs. And they have a rash that's a little different than the typical Kawasaki's rash, but they do actually get a rash. And they seem to have a thrombocytopenia as opposed to the opposite, which is what we see in Kawasaki's. So it's a very curious phenomenon. It's somewhat of a novel phenomenon, but it might actually help us to understand a little bit more about what even Kawasaki's is. But we don't know at this point. Nobody's really done any studies to figure out, why certain children are getting this versus others. And it is fortunately pretty uncommon. I wouldn't say rare yet, or at least not in this area, because we are seeing many admissions of older patients from this new disease. So I think we have a lot to learn, a lot of questions asked. They're sending off from the children's hospitals. They're sending off all kinds of tests related to the different cytokines that are drawn from the serum of these patients to learn more.
We have thank you. We have a couple of additional questions in the chat, and I know there's quite a lot of clinicians on the call, so please feel free to also jump in with responses to these, and we'll sort of hold that space for you in a second. So Anita Noble has written in to me saying, could someone address or at least mention the fact that many of the people are working in very busy units which are separating COVID and stable moms from their babies. They're sending babies back to the nursery, the moms to the regular COVID unit, and no contact between the mom and the baby, and mom is told to pump. Our hospital only has 2 bedded postpartum rooms. I would say that I've heard that in Mississippi too, that women are being sent to COVID units and then they can't even get the milk to the babies. And I think we must acknowledge that with all these goals that we have, there are some very basic problems that are going on. I don't know if anyone wants to address what Anita said before Laurie and I speak up anymore. Does anyone else want to talk about like how their units are dealing with some very suboptimal conditions for in basic cases? Anybody? Well,
I mean, I can talk about, go ahead.
Laurie, yeah, go ahead.
Yeah, I was just going to say, like in our hospital, so we know anyone who's worked with hospitals to get maternity care practices to align with the 10 steps. It takes years, it's not something that you can do overnight. And here we've had, COVID happen overnight with all these policy changes overnight. And it's just almost impossible, just the physical space and then everybody practicing in a way that is somewhat standardized and doing the same thing is nearly impossible. So we're finding out, all of the deficits of this guidance after the fact, really, that, oh yeah, well, we have units on 2 different floors, and oh yeah, we don't have enough staff or healthcare personnel to actually get the mom from the mother who's isolated to the baby. And oh, by the way, there's been nosocomial infections. So moms that are cohorted in the same room with a mom who might be unknown and then all of a sudden develop symptoms in a hospital where they're not doing universal testing. And lo and behold, only to find out that now the other mother sharing the room is positive, and then all the newborns end up being positive. So I think that, we have to be wise about how we carry out major changes to maternity care practices, because it's not just one thing that we're changing, it's really redesigning the entire structure of how we deliver care and who's delivering the care. And that's another compelling reason to say, wait a minute, maybe we just shouldn't change right now and do what we know how to do well in a standardized fashion and be as cautious as we can be to help prevent the spread of infection from mother to her baby. Because all of the other unanticipated consequences of changing the location of mothers and babies comes with just exponential number of other issues and problems.
Yes, I think it's also worth remembering, especially in states like Mississippi, where there's not a very high count. It's still going to be with us for a very long time. It's not going to go, well, it's highly, highly unlikely it's going to go away. And so even if, hospitals aren't on a constant basis being overloaded, they're still going to have to deal with some of these issues for a fairly long time. So there is going to be some time to work things out, because people will still be dealing with them. It's not like we work out emergency policy. Like, it's kind of like us all stuck at home, right? We all figured out how to grocery shop the first week, and then we're like, okay, this is going to go on forever. We need to figure this stuff out longer. And I kind of feel like that with the hospitals there, that we kind of, some people jump to emergency measures, which was fine, but actually we're going to have to figure out how to embed these going forward. I did have another question in the chat here from Karen, is it Bishop, who said, does anyone have a set policy of transporting or exchanging express breast milk from a sorry, does anyone have a set policy of transporting or exchanging express breast milk from a positive COVID mother and a NICU baby? If we're wiping containers, what do you use? I mean, that might not be something anyone can come up with right now, but I just asked Neonatal, and she has just typed the CHAMPS email address into the chat here. If people have questions or ideas.
The CDC has really good guidance on that. And, you know, it includes things like providing mother a dedicated pump, and then cleansing the pump components and the outside of containers, and then having a healthy caregiver transporting that express milk into the NICU to feed to that baby. So the CDC has pretty good guidance on that.
So you can go to the CDC's COVID site for that includes the mothers and babies, and look to see what would be helpful for your hospital there. Okay. So I just want to mention that Metal has written into the chat here at my request the CHAMPS breastfeed email, which is champs.breastfeed@gmail.com. If we have a lot of people on the call with a lot of questions, and potentially people who have responses or ideas for those questions. And also we're going to extend these webinars beyond the first week in June. So if you guys have any questions, either related to this webinar or just questions for our presenters or anything, please send them to the CHAMPS breastfeed Gmail, which is moderated by our team. And we can either respond to them or we can send them out to the relevant people. And so please just take that information down for the chat. And we're particularly interested to hear from, we have a big range of people on the call. So if you want to kind of follow us, I have noticed some people want some more information or want to be added to our list. Maytal is taking note of that too. We have one new question here, Laurie, that you might want to answer.
Yeah, I see it. Yeah, I can see it. I can read it. I've heard a great deal of concern about the theoretical concern of severe neonatal disease from SARS-CoV-2. Is anybody aware of such cases? So I think a good way to think about SARS-CoV-2 in the baby, and particularly in a vulnerable baby, a baby who's premature, for example, is somewhat like a late onset sepsis syndrome. And so it is possible that a baby that is exposed to COVID isn't sick immediately, but maybe a week or two later develops a syndrome similar to late onset sepsis. Most of those babies that have acquired COVID and do get sick like that may need to be hospitalized and may even need respiratory support, but almost every one of those babies has recovered fully and do fine. And they're extraordinarily rare. So I would say that, you know, given that they're rare, number one, and given that they recover from the immediate late onset sepsis-like disease, I would say that's not a reason not to directly breastfeed, and it's not a reason to think about changing what we're doing in the postpartum period after delivery. But I think it's important when we think about follow-up, you know, and really alert those pediatricians and other pediatric care providers, community workers, those that have a touch point to the mother and baby out in the community, that, you know, no one's really scot-free, you know, in this pandemic, that we have to always have our antennas up and be on the lookout for babies not feeding well, being lethargic, having fever, and, you know, have that visit, you know, face-to-face visit. Some things we just can't do by telemedicine, but we're learning how to do face-to-face healthcare better in a way that protects not only the patients, but also protects us and keeps us, you know, out there providing care. So we are better at figuring out how to use and reuse PPE and how to be there in the office and actually see patients. So it does happen, but it's rare.
Just to share the other something that came in the chat, Hambana has an infographic on milk transfer, but the writer says the CDC doesn't address the specifics. So I'm not, you know, again, send us some emails if you have very specific questions. I think you know, it's interesting to hear the different scenarios, like we only have so many rooms, or we only have so many pumps, or we only have so many places to store the milk. I know that UMC, that there was an issue that they didn't want to take the milk of a COVID positive mother into the NICU at all, in terms of storage, using the NICU storage space. So there are other things. Anybody else want to speak up that hasn't had a chance to write into the chat, or would like to just ask a question orally? We have about 5 more minutes.
So I can see here, Kate Bishop was having trouble finding the area on the CDC website that provided more information about express milk, and I can find that for you and send it to the team at CHAMPS. It's listed separately as breastfeeding guidance, so it should be there.
Anyone
Would
else?
I be allowed to ask another question?
Yes, go for it, of
Can I
course.
ask another?
Yes.
I'm so sorry. This is amazing. Thank you. I cannot thank you enough. I was wondering, I was asked to present this on a national scale, and I did not find any formal research that showed that there was actual antibodies of COVID-19 in breast milk. Are you aware of formal research that supports that these babies are getting immunity due to the from breast milk? Thank you so much.
Sure. So I know that there's an ongoing study, and it's a COVID study that is being conducted out of UC San Diego with Lars Bode lab and several other labs around the United States to actually examine mothers' milk. What I've heard anecdotally, and I don't have, obviously the study is still ongoing, but what I've heard anecdotally is that there's all kinds of antibodies, but IgA, from IgA to IgM and IgG antibodies in human milk. So, and I see here that Paula just posted that Fox has a paper about secretory IgA.
Has that paper been published, Paula? I see Paula Mayer, who's a great neonatologist and runs an NICU at Roche in Chicago. Paula, do you know if that paper's been actually published, the one that you just mentioned?
I unmuted myself. Can you hear?
Yes.
Hi, Paula.
Okay, so I'm sitting here looking at it because it came across the website that Lori was talking about, the Slack group working out of Ishmael. I'm just looking here. I don't know that it's been published. I know it was available. I'm happy to forward the copy of it. I know it's accepted for publication. I don't know how widely available it is, though. But it's called Evidence of a Significant Secretory IgA Dominant SARS-CoV Immune Response in Human Milk Following Recovery from COVID-19. So I'm happy to forward the copy of it to whomever would like to have it available on the site.
Thank you. I mean, I know there's an awful lot of research going on at a huge pace, and I'm sure that I'm sure you're not all competing, I'm sure everyone's working together, but I'm quite sure that very soon there's going to be data, because there are several big labs that have been funded to do this kind of research that work on human milk and the microbiome and all those kinds of things already. So stay tuned, everybody. The very beginning ones are starting to come out now. And so thank you, Paula, for mentioning that one. And Ishmael, yeah, there's an international study going on with Ishmael. So there will be stuff coming out, but to our knowledge, if there was a couple that were mentioned on our webinar last week, but they hadn't been reviewed or published. So I just want to make sure that everyone's careful, because, once a paper does come out that either finds antibodies or finds the virus in the milk, we don't know what that means. We won't know what that means, the volume of them. I mean, we don't very much at all about the virus. So, the minute it appears, everyone's going to either freak out or say, hooray, we knew. And we have to be careful, because it's very preliminary, but it is being done. The research is being done. So I'm sure it won't be long before some of it comes out.
Yeah, and with that, I go back to the study that just came out on the Virome. We know viruses are in human milk, but then when we look at the babies, I think it's really interesting to see how human milk, again, acts to modulate what ends up happening in the baby. So it's really just looking at one side of the coin. If all you're looking at is what's in human milk, I think we have to really understand the dyad to understand the full picture.
Thanks. And I think, okay, so Paul, we have got some more comments, which I'm sure you see in the chat, about which ones has been published, blah, blah, blah. Yep. It's important, says Paula, to understand that if the impact given on them may be given them multiple mechanisms, blah, blah, blah. Okay, guys, before we wrap up, I just want to sort of thank Laurie and Alison and Anne, because we really kind of hijacked their original study, and someone just said thank you for this original study, which was really the review article, which was a state-of-the-art review article in pediatrics about exclusive breastfeeding. Don't forget that in the big sort of rush to deal with COVID, because it was a great article, and that was the original inspiration behind this webinar. So I just want to thank everyone for staying on. We still have almost 100 people on the line, and thank you, Laurie, for keeping chatting. Is there anything you want to wrap up with, Laurie, before we close?
No, thank you for having us. I think that the state-of-the-art review is timely, and there's no better time to actually look at what we put together, because all those same issues are still at play. Plus, we have COVID, and this time more than ever, it's important to support exclusive breastfeeding. So thank you for having us.
And thank you for the person that said here that this is by far the best webinar. I'll just end with this. This is by far the greatest webinar I have participated in on COVID-19 so far. Clear, practical, and presented in an exceptional manner. So thank you all. I know a lot of work went into this from behind the scenes, and then particularly from our three presenters. So thank you all. We will wrap it up. We will keep reading all the messages in the chat. Everyone has our email address, and look at our CHAMPS website, which I also put in here earlier on, if you want to get in touch with us. And we are going to extend out the presentations into June, so anyone that wants to participate or listen in, thank you. And thanks very much, and thanks, Laurie, for gluing it all together so much and so well. Thank you, everybody, for your time. Take care.